I'm going to be summarizing key principles from a document entitled Joint Principles of the PCMH. This was jointly authored by 4 specialty groups: the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Physicians, which is an internal medicine group, and finally the American Osteopathic Association. I'll be using some of these abbreviations during the course of my presentation. Some key principles. First of all, the team approach. One of the hallmarks of the patient-centered medical home is that the physician will continue to be the overseer and captain of the ship. However, one of the principles is that other health professionals, whether they be nurse practitioners, physician assistants, physical therapists, and especially medical assistants, will be expected to work together with the overseeing physician to provide care to the patient that is coordinated and that is sensitive to the needs of the patient. So the collective responsibility for the health of patients is one of the main features of the patient-centered medical home. Secondly, a whole person orientation. These team members must be able to communicate empathically with patients. They must be careful listeners. They must also be able to communicate in such a way that the patients understand what is being recommended. You've probably read the studies that show that some of the reasons why health outcomes are not as good as they could be is because patients really don't understand what the physician is telling them. By enhancing this communication and dealing with the whole person, the patient-centered medical home hopes to eliminate instances of patients not understanding what the diagnosis is and what the treatment is going to be. Thirdly, patient advocacy. The point here is that throughout the health system, a patient has to have someone who is coordinating the care for the patient. The CMA AAMA is an ideal person for this because of the education and credentialing that they have. So in this entry-level point of primary care, the idea is that there will be patient advocates who will help the patient after he or she leaves the office. So the idea of coordination, having a home base, but having someone who will be able to help you, go to bat for you throughout the whole process, is one of the key points of the patient-centered medical home. And finally, enhanced access to care, open scheduling, group appointments, an emphasis on electronic medical records. All of these are various elements to try to bring together the divergent players in the health field at this point in time. I'd like all of you to think about the following questions, and I'd like you to come this afternoon or even this morning if you'd like to share with us. First of all, have you seen any elements of the patient-centered medical home in your work? It may not be called that. There are other names that are given to it, but any features of the PCMH that you have seen in your work as a medical assistant. And secondly, how specifically have you, as a CMA AAMA, been involved in the evolution of care to this patient-centered medical home? If you could think about those questions and share with us either this morning or this afternoon, that would be greatly appreciated. Next point, line 22. How the PCMH movement has already helped medical assisting and CMAs AAMA. This is not just a pie-in-the-sky, long-term objective. There are good things that have already happened, tangible good things. First of all, line 24, at the Annual Conference on Practice Improvement, which is sponsored by the American Academy of Family Physicians, which I attended in Savannah, Georgia last December, I'm happy to report that truly everyone there knew who medical assistants were. I've been going to these medical meetings for many years, and one of the frustrations that I have had is that many of the people who should know better confuse medical assistants with physician assistants or nursing assistants, whatever. I was very surprised and pleasantly surprised to find out that there was no need to explain that to anyone, because everyone there, whether office administrator, office manager, physicians, other health professionals, insurance people, everyone there, and of course they've been interested in the patient-centered medical home for a few years now, but everyone knew who a medical assistant was. So if you want some positive build-up, I suggest you go to this next meeting, which is going to be in Kansas City in November, because you'll be well received and you'll actually be treated as a VIP once you indicate that you are a medical assistant. Now, to be honest, I can't say that everyone there knew who a CMA AAMA was, or the difference between a medical assistant who had formal education and was trained on the job, one who had the CMA AAMA, the difference between our credential and the RMA. I did receive many questions from people about that, so that is something we need to work on. But we finally have a forum in which medical assistants are well known, and we can build on that. We don't have to start at the ground level to educate these people as to who medical assistants are. Point number 2, I think you've seen the letters that are present outside from these 3 of these 4 specialty groups, indicating that they have appreciated our partnership with them, that they know who the AAMA is, and they're eager to work with us in the future on very concrete projects. So if you haven't seen those, please notice them on the stands outside. The next point is that we have become members of the Patient-Centered Primary Care Collaborative. This is the advocacy arm of the PCMH movement. As you see in the description, this consists of physician organizations, insurance groups, labor unions, consumer health groups, a very wide array of organizations who are working together to try to improve access and quality of care for all Americans. They have meetings in Washington, D.C., and their main efforts are working with legislators, executive branch people, in an effort to make sure that the primary care dimension of health care is not neglected. They also have monthly teleconferences in which there are updates on legislation, how different bills are progressing through the Senate and the House of Representatives. So we are honored to be a part of this PCC, and I will be, as I mentioned, going to another meeting in Washington, D.C. next month. The next point is our alliance with the American Academy of Pediatrics. I was asked to write an article entitled "The CMA AAMA, an Invaluable Asset for the Pediatric Office," and that was posted on the online practice management section of the AAP website. So if any of you work in pediatrics or are interested in that field, you should know that the AAP has become very supportive and very aware of the AAMA and the CMA AAMA credential. Now, these next 2 go together. Both the American College of Physicians and the American Academy of Family Physicians have posted a link to the AAMA website, specifically the scope of practice section. And as a result of that, we have had more physicians who have become aware of what is legal and not legal to delegate in the state. And that really is a very important part of my day-to-day responsibilities at the AAMA Executive Office. I probably receive 12 emails and 4 telephone calls a day asking, is it legal for a medical assistant to do X, Y, and Z in my state? Those calls come from physicians, from practice managers, from medical assistants themselves. We have posted some of the states, not all of them, and that's intentionally, but we have posted some of the states on our website, and we also advise anyone who does not find the state on the website to email me, and I will give an answer as to what the Practice Act permits physicians to delegate in that state. So links have been posted to our scope of practice section of the website, both on the Family Physicians and the American College of Physicians, and I have been receiving even more inquiries from members of these organizations as to what is legal in the various states. Another point that is very important is that we have been asked to write a letter of support on behalf of the American Academy of Pediatrics efforts to receive grant funding for the CDC's Childhood Immunization Support Project. This again is indicative of the fact that they really see us as equal partners, the AAP. It's not as if we're just going to them and asking them to help us. What can you do for us? They are reciprocating and realize that we are a powerful, influential group, and they're asking us to write letters in support of their initiatives. So I think that's very significant in and of itself. Finally, the American College of Physicians has asked us to put together a webinar involving one internist, general practice internist, and a CMA AAMA to be able to talk about how the partnership in an internal medicine office works with the physicians and the CMAs AAMA, and they would hope to be able to put that on their website and initially roll it out as a program that their members would be able to attend. So this is another question that I'd like you to think about and help me with. If any of you know of an internist who works with a CMA AAMA but in a patient-centered medical home environment, again, it doesn't have to be called that, but it does have to have these features of the patient-centered medical home. If you could let me know sometime during the course of this meeting, I would appreciate that very greatly. If we have those parties lined up, we'll be able to move forward with this webinar. Let's move on to the next point, but are there any questions or comments before we go forward, realizing that there will be opportunities this afternoon as well? Anything at all at this point? Okay, well, let's move forward. Line 46, we were able to have one of my articles published in MagMutual's Healthcare Risk Manager. MagMutual is a malpractice insurance carrier which serves Georgia, North Carolina, and South Carolina, I believe, stemming from a question as to what, again, medical assistants, what CMAs AAMA can and cannot do. My full article is posted on their website. This is not directly related to the patient-centered medical home, but it is a good indication of how sometimes work for many years bears fruit at unexpected times and sometimes in unexpected ways. Legislation was passed by the Georgia General Assembly that clearly mentions medical assisting in the statutes, and that is a definite positive for that state and that region of the country. The next main point is how the PCMH movement will help medical assisting and the CMA AAMA. The first point I'd like to bring to your consideration is that what we're doing here with our PCMH work is a type of marketing. It might not be what we traditionally think of marketing as print ads or other media, but by getting involved in this movement and making ourselves known to these specialty groups, that is really a very powerful way of getting the profession, the credential, and the association understood and recognized. Secondly, I want to talk about the importance of getting legal existence for medical assistants or legal identity. By being involved in the PCMH movement, when regulations are being written, either on the federal or state level, when legislation is being considered. Because of our higher visibility, we are getting mentioned in state bills and even federal legislation, which we would not have been but for the PCMH movement. And as a result, by being recognized as such, as medical assistants per se, in the laws, that will give us a jumping off point for which we can get recognition of the CMA AAMA. And my next point is legal differentiation. The ultimate objective is to result in laws which will differentiate what is legally delegable to CMAs AAMA as opposed to all other medical assistants. So the legal existence or identity or being written into the laws is a first step. A second step, sometimes we can do them together, sometimes we can't, is to obtain this differentiation in the law between what CMAs AAMA can do and all other medical assistants. And the PCMH movement is really driving us in the direction of obtaining these various goals. Point number 4 on line 58, I've been getting more right-to-practice questions in the last 6 months about telephone screening. Is it legal for physicians to delegate telephone screening to medical assistants? And some of you know from the articles I have written that I differentiate between telephone triage, which I define as exercising independent professional judgment, similar to what a physician assistant or a nurse practitioner would do, and telephone screening, which I define as following physician-approved protocols, decision trees, algorithms, whatever. And so I am strongly arguing the case that, based on this differentiation, that yes, it is legal for physicians to delegate telephone screening to competent and knowledgeable medical assistants. And that, I think, has been very helpful. This year, just these last few months, I've been getting many questions on whether it is legally permissible for medical assistants to do influenza vaccines, not only under a physician's direct supervision, but under pharmacist supervision or in remote sites. So that presents a very interesting legal opportunity, but we can't go too far either. But at least it shows that we're being asked to do things that we would not have been asked to do even as recently as 3 or 4 years ago. And finally, and interestingly, I seem to be getting an uptick in questions about limited scope radiography. That was more prominent in our accreditation standards 15 years ago, but it really had become sort of a dead letter. So I don't know whether this is a trend, but I am getting more questions as to whether in this state can physicians delegate limited scope radiography. So what I'd like you to think about is whether you're seeing CMAs AAMA being asked to do more of this telephone screening, any type of administration of medication. I'm particularly curious about the influenza vaccine issue and limited scope radiography, or whether you can share with us any other duties that are somewhat new to the CMA AAMA realm. Point 5, there's a lot of opinions as to what we should do about American health reform. I don't envy President Obama. I'm not here with people shouting at me saying that the plans are bad or good, whatever. And that's very important, and I'm sure all of you as good citizens are following that debate as much as you can. But regardless of how you feel about that, this debate about health reform is driving this patient-centered medical home movement and is being very positively beneficial for the medical assisting profession. So we need to take advantage of that momentum regardless of the larger public policy issues. Point 6, I really see a new hope here that goes beyond our traditional public policy and our traditional marketing direction, and that is the following. Line 62, possibility of reimbursement for certain duties only if they are done by CMAs, AAMA, not by other medical assistants. This is similar to this legal differentiation, but it's driven not by laws, but by reimbursement policies, whether it be federal reimbursement or reimbursement by non-governmental third-party payers. This is not just, again, a pie in the sky, something we'd like to shoot for. I point your attention to line 64, the Office of Inspector General's report entitled Prevalence and Qualifications of Non-Physicians Who Performed Medicare Physician Services. Now, this was a study that was initiated by concerns over whether physicians billing Incident 2 services to Medicare were somehow delegating these to people who are not qualified, and whether the public health was being jeopardized by that, whether the federal government was paying for services that were not up to standard. So the acting administrator of the CMS wrote to the Inspector General as follows. CMS is currently in the process of clarifying the manual policies relative to services incident to physician services. We will provide improved guidance for documenting the qualifications of the person performing services billed to Medicare by physicians and these non-physician practitioners who may bill services incident to their services. So CMS is basically saying they're going to start looking at to whom these incident to services are being delegated for the purpose of determining whether they're being delegated to competent, capable people. You could see that as a threat. They might say that, well, some duties can no longer be delegated to medical assistants, even if they're CMAs, AAMA. However, I see this as an opportunity to let them know that CMAs, AAMA, who are formally educated, credentialed, currently competent, are the ones to whom these incident 2 procedures should be delegated. This gives me hope that this reimbursement strategy, different from the legislative strategy, could also bear significant fruit in the near future. The final point is language from this document that we hope to be able to roll out. The CMA AAMA advantage, why CMAs AAMA are ideal for the patient-centered medical home. First, we point out, and this is a promotional piece, granted, but these are facts that we can substantiate and support. CMAs AAMA are the only allied health professionals specifically educated to work in outpatient delivery settings, such as patient-centered medical homes. The fact that the pathway for the CMA AAMA certification examination is only for those who have graduated from a KHEP or ABHES accredited medical assisting program allows us to say this with great confidence. You may know that there are some school programs, secondary and post-secondary, that just take one slice out of the medical assisting scope of practice and teach it. So we have people who are graduating from short programs that are administrative medical assisting programs, or short programs that are clinical medical assisting programs. But because the standards of KHEP indicate that only those who show knowledge and competency in all areas can graduate from such a program and can be eligible for the test, we can make this assertion very confidently and forcefully. Secondly, we can also say that CMAs AAMA are the only allied health professionals who have passed a standardized National Board of Medical Examiners examination accredited by the National Commission for Certifying Agencies. The NBME designation still is very recognizable and respected, especially in the larger medical and health communities. And the NCCA accreditation, which the certifying board obtained 3 years ago, is very well known in federal circles. So by mentioning both of these, we are distinguishing in concrete terms how the CMA AAMA truly is the gold standard. The next point, unlike some licensed health professionals, the CMA's AAMA must recertify every 5 years and cannot use the credential unless it is current. We really have a great advantage when we can point to the fact that there are many states in which RNs and LPNs, for example, do not need to show continuing competence. That's changing. The nursing community is encouraging all of its boards of nursing in each state to lobby its legislature to mandate nurses having to get continuing education every 3 years, 5 years, 7 years, whatever. Nevertheless, there are still probably 15 states or 20 states that do not have these continuing competency requirements for RNs or LPNs or LVNs, and we can use this quite significantly to our advantage in talking with these federal and state regulators. And finally, I make the point that an increasing number of malpractice insurance carriers are requiring medical assistants to be CMAs. A small number, but an increasing number. And the good news is that there are malpractice insurance carriers that are involved in this patient-centered coalition, and they are aware of the fact that the CMAs AAMA are those who have been formally educated in an accredited program and have passed a standardized, nationally recognized accredited test. And the final end result is that we are urging all decision makers to take advantage of the CMA AAMA advantage and hire CMAs AAMA for patient-centered medical homes.